Welcome back to the deep dive. Our mission today, well, it's pretty straightforward. We're giving you the ultimate shortcut into understanding the pharmacological fight against high cholesterol.
hmm
This deep dive is all about antilipemic drugs. You know, the front line in preventing major cardiovascular events.
That's exactly right. We are really unpacking the core insights from Chapter 29 here. We're focusing on the pathophysiology of lipid abnormalities,
Mm.
the precise mechanisms of the different drug classes,
Right.
and the essential clinical considerations, especially for Canadian healthcare practice. This stuff is absolutely paramount because, well, we're talking about lowering the risk for cardiovascular disease, CAD.
Which is huge in Canada.
Oh, absolutely. One of the leading causes of mortality.
Okay, so let's nail down our foundation first. When we talk about antilipemic drugs, we mean agents that reduce lipids floating around in the blood.
hmm
We're focused on two main players here. Triglycerides, they're mostly for energy storage, right?
Yep. Stored in adipose tissue.
And cholesterol, which is, well, essential for things like steroid hormones, building cell membranes, making bile acids.
Exactly. The problem isn't the lipids themselves. It's more about how they move around. See, they're water insoluble.
So they can't just dissolve in blood.
Precisely. They can't just float around freely. They need specific carriers,
Mhm.
and these are called lipoproteins.
Okay, let's unpack that transport system then. These lipoproteins, you describe them as microscopic delivery trucks, which I like. They get classified by their density.
Yeah, basically how much fat or lipid they're carrying versus how much protein structure they have.
Hmm?
Think about table 29.1. If you have the text, chylomicrons have the most lipid, HDL has the least.
Gotcha. So where does the journey start? Diet?
Usually, yeah.
Good.
Let's try again. Dietary fat, what we call exogenous lipids,
Yep.
gets packaged up into chylomicrons. These are the lowest density trucks, like big moving vans. They carry that fat from the intestine mainly to the liver. Then the liver has its own job packaging up the fat it makes, the endogenous lipids. And it sends those out in VLDL, very low density lipoprotein, trucks to the rest of the body, the peripheral cells.
Okay, so VLDL is carrying the liver's manufactured fat out. This is where the risk factor starts to creep in, isn't it?
It is. Think of VLDL dropping off its main cargo triglycerides to cells that need energy.
Okay.
Once it's delivered most of that fat, it changes, becomes denser, morphs into the infamous LDL, low-density lipoprotein.
Ah, the bad cholesterol.
That's the one. LDL now contains mostly cholesterol. Its job is delivering that cholesterol, but if you have too much LDL circulating, well, that's a lot of cholesterol just waiting to cause trouble.
Hence the strong link to CAD.
Exactly. High LDL levels are a major red flag.
But hang on, not all cholesterol is bad news. We need to talk about HDL, right? High-density lipoprotein.
Absolutely. HDL is kind of like the cleanup crew. It's produced in the liver and intestines.
And it's cardioprotective.
Very much so. It performs what's called reverse cholesterol transport. It basically goes around, picks up unused cholesterol from peripheral cells, and hauls it back to the liver.
For disposal, essentially.
Right, for excretion. So a high HDL level, that's generally a good thing.
Okay, this is where it gets really interesting for me. The actual atherosclerotic plaque formation, how does that happen?
It usually starts small, with repeated microscopic injury to the artery wall. Think things like chronic high blood pressure, smoking, maybe diabetes.
Constant irritation.
Yeah, exactly.
Yeah.
That triggers an inflammatory response in the artery wall.
And inflammation plus high cholesterol is the bad combo.
That's the danger zone. That inflammation makes the LDLs floating by more likely to get trapped and, crucially, oxidized.
I don't need LDL. Okay.
Then circulating immune cells, monocytes, squeeze into the artery wall. They transform into macrophage cells. And these macrophages just gorge themselves on that oxidized LDL.
They eat it.
They literally engulf it. And these bloated, lipid-stuffed macrophages, those are what we call foam
The
cells.
foam cells, got it.
Those foam cells are the hallmark initial lesion of atherosclerosis. They form what's called a fatty streak. Over time, this process continues. The plaque builds up, narrows the artery.
Stiffens it up.
Exactly. And eventually that can lead to a heart attack or stroke. The clinical risk is, well, it's serious. Your risk for CAD is like 3 to 4 times greater if your cholesterol's up around 5.2 millimole compared to someone below 4 millimole.
Wow. Okay, so prevention is key. And the Canadian guidelines emphasize lifestyle first, right? Diet, exercise.
Absolutely. But before we even think about drugs, it's about lifestyle modification. Things like the DISH diet, Mediterranean, even vegetarian or mind-eye diets, plus regular exercise. That's always the foundation.
But sometimes that's not enough.
Often it isn't enough to hit those target lipid levels, especially for higher risk people. And that's when we bring in the pharmacological arsenal. There are 5 main established classes of antilipemics we really need to get into.
All right, let's do it. And we absolutely have to start with the big guns, the first-line therapy for high LDL, the HMG-CoA reductase inhibitors. Everyone knows them as statins.
The reigning champs, for sure.
Yeah.
And the mechanism of action is pretty elegant. It's like molecular biohacking. Statins competitively inhibit an enzyme called HMG-CoA reductase.
And that enzyme is important because
It's the single rate-limiting enzyme in the liver's own cholesterol synthesis pathway.
Mhm.
Basically, it's the main bottleneck for making cholesterol inside the liver.
So block that enzyme.
And the liver makes less cholesterol internally. Simple as that.
But then the liver compensates, right? You mentioned that.
It does, quite cleverly. Since it's not making enough cholesterol itself, it gets hungry for it from the outside. So it dramatically increases the number of LDL receptors on its surface.
Like putting out more landing pads for the LDL trucks?
Exactly. It essentially forces the liver to vacuum up LDL cholesterol from the bloodstream to meet its needs. Very effective at lowering LDL-C.
Okay, statins are potent, but we have to talk adverse effects immediately. These are crucial.
Absolutely crucial. Generally, they're well tolerated, but the most clinically important side effect is myopathy. That's muscle pain or weakness.
And that can get serious.
In rare cases, yes. It can progress to a severe, potentially life-threatening condition called rhabdomyolysis.
Rhabdo? Okay, what's happening there?
That's the breakdown of muscle protein. The byproduct, myoglobin, gets released into the blood, and it can basically clog up the kidneys,
Right.
potentially causing acute kidney injury.
Okay, that sounds really bad. So what are the warning signs?
Patients absolutely must report any unexplained muscle soreness, tenderness, or weakness. Also, changes in urine color, specifically dark tea-colored urine that's a major red flag. Fever, nausea, vomiting too.
And certain people are at higher risk.
Yes. Factors include being over 65, having hypothyroidism, existing kidney problems, or taking certain other drugs concurrently like some antifungals or antibiotics, or, importantly, the fibrate gemfibrozil we'll discuss later.
And there is a specific note about rosuvastatin.
Right. The source material highlights that patients of Asian descent have a higher risk of rhabdomyolysis with rosuvastatin, particularly at higher doses.
Right.
The 40 milligram dose is actually contraindicated for them.
Good to know. And the grapefruit juice thing, that's real.
Oh, absolutely real and clinically significant. Grapefruit juice contains compounds that inhibit or inactivate an enzyme called CYP3A4 in the gut wall. Several statins, like simvastatin and atorvastatin, are metabolized by this enzyme. So if you drink grapefruit juice, the enzyme gets knocked out. The statin doesn't get broken down properly.
And the levels in the blood shoot up?
Exactly. Drug levels stay high for longer,
Hmm.
dramatically increasing the risk of toxicity, including that dangerous rhabdomyolysis. It's a non-negotiable teaching point for patients on those specific statins.
Wow. Okay, so statins work inside the liver. What about the bile acid sequestrants? They work differently, right? More mechanical.
That's a great way to put it. They take a completely different approach,
Yeah.
targeting the gut. Think drugs like cholestyramine, cholestyramine.
How do they work?
They basically bind onto bile acids in the small intestine. They form this large, insoluble complex that can't be reabsorbed back into the body.
So it just passes through.
Right, it gets excreted in the feces. Now, the body normally recycles bile acids very efficiently, and it uses cholesterol to make bile acids in the liver.
Ah, I see where this is going.
Exactly. By forcing the excretion of bile acids, you make the liver use up more of its cholesterol stores to synthesize new bile acids. This lowers the overall circulating cholesterol level, especially LDL.
Effective, but I hear the side effects can be rough. GI stuff.
Notoriously so. Constipation, bloating, abdominal discomfort, these are very common and can really impact adherence.
And there's a specific warning for cholestyramine, too.
Yes, a critical one.
Mm-hmm.
Cholestyramine formulations often contain aspartame. This makes it strictly contraindicated in patients with phenylketonuria, PKU, a genetic disorder where they can't metabolize phenylalanine, a component of aspartame.
Okay, that's crucial. But the adherence challenge you mentioned before, the drug interactions.
This is probably the biggest clinical challenge with this class. Bile acid sequestrants are sticky, essentially. They can bind up other oral medications in the gut, preventing their absorption.
So other meds just don't work as well.
Exactly. And this also applies to fat-soluble vitamins A, D, E, and K.
So how do patients manage that?
Strict timing is essential. The rule is, take all other oral medications either 1 hour before taking the sequestrant or wait 4 to 6 hours after taking it.
Wow, that sounds incredibly difficult to manage long term. That must be a huge counseling point.
It's the absolute critical nursing point for this class. Get the timing wrong, and other vital medications might not be absorbed properly.
And you mentioned powder forms.
Right. If it's a powder, like cholestyramine often is, it must never be taken dry.
Hmm.
Always mix it thoroughly with plenty of fluids, water, juice, whatever's recommended to avoid irritating or obstructing the esophagus. And increasing overall fluid and fiber intake helps with that constipation too.
Okay. Moving on. What about drugs that really target triglycerides more than LDL?
That would primarily be the fibric acid derivatives, or fibrates. Think gemfibrozil and fenofibrate.
Fibrates for triglycerides. Got it.
They are highly effective for lowering high triglyceride levels. They can also provide a nice boost to HDL-C, maybe up to 25%.
How do they pull that off?
Their main mechanism involves activating an enzyme called lipoprotein lipase. This enzyme is key for breaking down triglyceride-rich lipoproteins like VLDL.
Makes sense. Any major contraindications?
Yes. They can increase the risk of forming gallstones, so they're generally contraindicated in people with pre-existing severe liver disease, kidney disease, or gallbladder disease.
And the statin interaction again?
Huge warning here. Combining fibrates, especially gemfibrozil, with statins significantly increases the risk for myositis, myopathy, and that severe rhabdomyolysis.
So using both together needs extreme caution or is avoided.
Often avoided or requires very careful monitoring in lower doses. It's a known serious interaction because you're hitting muscle tissue potentially from two different angles.
Okay, that's a recurring theme. What about nicotinic acid? That's niacin, right? Vitamin B3.
It is, yes, but we're talking about using it in much, much larger pharmacological doses than you'd get from a standard vitamin supplement.
And it's unique.
It's interesting because it favorably affects all the lipoproteins. It lowers LDL, lowers triglycerides, and it's actually one of the most effective agents for significantly raising HDL levels.
How does it work?
Its beneficial effects seem to come from inhibiting lipolysis, the breakdown of fat in adipose tissue, and maybe increasing lipoprotein lipase activity too.
Sounds great, but there's a catch, right? The side effects.
Oh, yeah. The main limiting factor for niacin is an intense, often unavoidable side effect: cutaneous flushing and pruritus. That means intense redness and itching of the skin.
Why does that happen?
It's caused by the release of prostaglandins in the skin. It's usually harmless, but extremely uncomfortable for patients. Feels like a really bad sunburn sometimes.
Is there anything you can do about that?
Thankfully, yes. There's a simple trick. Taking a small dose of aspirin or another NSAID about 30 minutes before taking the niacin dose can significantly blunt that prostaglandin release and minimize the flushing.
That's a really practical tip. Makes it much more tolerable.
Absolutely. Yeah. Without that pre-treatment, many patients just can't stick with niacin therapy. Oh, and also remember the interaction. Increased risk of myopathy when combined with a statin here too.
Right. Always watch those combos. Okay, finally, let's briefly touch on the newer kids on the block, ezetimibe.
Right, ezetimibe. This one's a cholesterol absorption inhibitor.
So it works in the gut too, but differently than the sequestrant.
Exactly. It selectively targets and inhibits the absorption of cholesterol right at the brush border of the small intestine.
Yeah.
It blocks that pathway. It's often used as an add-on therapy with a statin to get LDL even lower.
Okay. And the really powerful ones, the injectables.
Ah, yes. The PCSK9 inhibitors. These are monoclonal antibodies, drugs like evolocumab or elucumab.
And who gets these? They sound serious.
They are powerful and typically reserved for higher-risk patients. The 2021 Canadian guidelines recommend them mainly for secondary prevention.
Meaning people who've already had a heart attack or stroke.
Yes, or those at very high risk for one. And specifically, patients who are already on the maximum tolerated dose of a statin, but their LDL cholesterol is still too high. The guideline mentions above 1.8 millimoles specifically.
So it's for tough cases where statins alone aren't enough.
Precisely. They offer another way to dramatically lower LDL, really pushing the boundaries of treatment intensity.
Okay, we've covered the arsenal. Let's pivot to the practical side, the nursing process. What's key when starting someone on these meds?
The initial assessment is absolutely paramount. Before starting any antilipemic, you have to do a thorough check for contraindications. Well, active or serious liver disease is a big one, especially for statins and fibrates. We mentioned PKU for cholestyramine, gallbladder disease for fibrates. You need the full picture.
And baseline lab work is essential, I imagine.
Non-negotiable. You need a full lipid panel, obviously total cholesterol, LDL, HDL, triglycerides. But just as importantly, you need baseline liver function tests.
AST and ALT.
Yes. Aspartate aminotransferase and alanine aminotransferase. These are liver enzymes. You need to know the baseline before starting drugs that are metabolized by or potentially toxic to the liver.
And anything else?
Yes, creatine kinase, or CK, that's the muscle enzyme. You need a baseline CK level, especially before starting a statin or fibrate, so you can monitor for muscle issues later.
Why is monitoring CK so important?
Because if a patient on, say, a statin starts complaining of muscle aches or weakness myopathy, checking their CK level is how you objectively assess if there's muscle damage occurring. A significantly elevated CK can indicate rhabdomyolysis is developing.
Got it. So it's not just about the lipid numbers, but the whole patient risk profile?
Exactly. You assess all those risk factors mentioned in box 29.1 in the text stage: smoking history, hypertension, diabetes, family history of premature CAD, and their specific lipid levels. It's the total picture.
Okay, let's crystallize the most critical patient teaching points for someone listening. What do they absolutely need to tell patients?
Right, for statins, the number one message is about vigilance for muscle problems. Tell them. Immediately report any unexplained muscle soreness, tenderness, weakness. Also report fever, nausea, or crucially, any changes in urine color, especially that dark tea-colored urine.
And the grapefruit reminder.
And absolutely hammer home the grapefruit interaction if they're on a susceptible statin like simvastatin or atorvastatin. No grapefruit or grapefruit juice, period. Take the pill with water or meals as directed.
Okay, for bile acid sequestrants.
The critical message is timing and mixing. They must take other oral meds either 1 hour before or 4 to 6 hours after the sequestrant. No exceptions. And if it's a powder, mix it thoroughly with fluids, never take it dry.
And managing side effects.
Encourage increased fluid and fiber intake to help manage the almost inevitable constipation.
Good tips. And the overall message for any of these drugs?
The big picture is that therapy for dyslipidemia is usually a long-term commitment, often lifelong.
It's not a quick fix.
Not at all. It requires consistent follow-up appointments to monitor how well the drug is working, are the lipid levels hitting target, and just as importantly, to monitor for potential adverse effects, especially checking liver function and watching for muscle issues.
So the goal is always lowering LDL and triglycerides.
While keeping those HDL levels up if possible, and critically, maintaining those lifestyle changes, diet, exercise, smoking cessation. The drugs work with lifestyle changes, not instead of them.
We've really covered the whole journey, haven't we? From how lipids get transported.
All the way to the specific molecular ways these drugs intervene, whether it's blocking an enzyme in the liver or binding things up in the gut. Understanding how they work is really key to understanding the risks and benefits.
Okay, so here's the final thought for you, the listener. What does this all mean in practice? Think about the challenge of patient adherence. Managing a long-term condition like high cholesterol, which often has zero symptoms day to day. That's tough.
It really is.
Now, consider a drug like a bile acid sequestrant that demands that really disruptive timing, taking it hours apart from everything else every single day. Or maybe a statin that causes some mild, nagging muscle discomfort. How can knowing the mechanism, really understanding that this drug is physically binding bile acid, or that one is shutting down the key cholesterol factory enzyme, how can that deeper knowledge help you counsel your patient more effectively? How can it help you empower them to stick with the therapy long term, even when it's inconvenient or causes minor side effects?
That insight into translating mechanism into motivation, that's powerful.
That's really what we're aiming for here.
A provocative thought to end on. Thank you for joining us for this deep dive into the world of antilipemic therapy, all grounded in those essentials from Lilley's Pharmacology for Canadian healthcare practice.
And a warm thank you from all of us here at the Last Minute Lecture team. We'll catch you on the next deep dive.